Welcome to our video on diseases of the pulmonary vasculature. Let's begin. In this lecture, we'll talk about cor pulmonale and pulmonary embolism. Let's start with cor pulmonale. For cor pulmonale, we'll discuss definition, pathophysiology, etiology, clinical presentation, diagnosis, and management. Cor pulmonale is an isolated right-sided heart failure due to lung disease. Let's talk about pathophysiology. Acute or chronic lung diseases can cause hypoxia. Hypoxia, in turn, induces hypoxic pulmonary vasoconstriction, increasing the right ventricular afterload. Increased afterload results in concentric right ventricular hypertrophy, which finally causes right-sided heart failure. Here is a gross image of heart showing right ventricular hypertrophy. As a result of long-standing hypoxic pulmonary vasoconstriction, also referred to as cor pulmonale. Take a minute to appreciate that while the right ventricle is hypertrophied and dilated, the left ventricle appears normal in size, which is consistent with cor pulmonale. These are the lung diseases commonly implicated in the pathogenesis of cor pulmonale. It's not a comprehensive list, but it demonstrates the pathophysiology well. Chronic obstructive pulmonary disease, diffuse parenchymal lung disease, asthma, cystic fibrosis, and pneumoconiosis can all result in hypoxia, which will initiate the pathway that we described on the previous slide. Let's move on to clinical presentation. Cor pulmonale commonly presents with decreased exercise tolerance and fatigue. On physical exam, a loud P2 heart sound is detected due to high pulmonary vascular pressure. Left parasternal heave is caused by concentric right ventricular hypertrophy due to increased right ventricular afterload. Right-sided heart failure will manifest with jugular venous distension, ascites, hepatomegaly, and peripheral edema due to backup of blood in the systemic veins. Finally, chronic lung disease underlying cor pulmonale can induce cyanosis and clubbing. This is an image of a patient with digital clubbing. Please pay attention to the hypertrophic soft tissue over the distal phalanges. It's important to remember that digital clubbing can be seen in diseases that cause chronic hypoxia, but it can also be a paraneoplastic syndrome related to lung cancer. Be sure to keep this in mind when reading through questions with patients with chronic lung disease due to smoking. Diagnostic findings of cor pulmonale are almost identical to those of pulmonary hypertension. Electrocardiography of the patient with cor pulmonale will also show right axis deviation due to right ventricular hypertrophy and P pulmonale due to right atrial dilation. Chest X-ray will reveal enlarged pulmonary arteries and findings of any underlying lung disease that led to the cor pulmonale. Echocardiography will show a dilated right atrium and ventricle, right ventricular hypertrophy, and enlarged pulmonary arteries. Let's move on to management. First, the underlying disease should always be addressed and treated when possible. Management may also include home oxygen therapy. Diuretics should be used cautiously because patients with cor pulmonale are preload dependent. This means that right ventricular end diastolic volume is already decreased due to ventricular concentric hypertrophy. If we decrease the total volume in the patient's body, then the right ventricular end diastolic volume will be further decreased and the overall cardiac output will deteriorate. Digoxin can be prescribed in some cases to improve contractility. Finally, the pulmonary vasodilators that we discussed for pulmonary hypertension are not commonly used in cor pulmonale. This is because pulmonary vasodilators will retain blood in the pulmonary vasculature. This in turn will decrease the left ventricular venous return and cardiac output. A 65-year-old man comes to the physician due to leg swelling that he first noticed 5 months ago. He was diagnosed with chronic obstructive pulmonary disease 10 years ago. The physical exam reveals jugular venous distension, hepatomegaly, bilateral lower extremity edema. His PaO2 is 60. What is the most likely pathophysiology of this patient's current condition? This patient with a long history of chronic obstructive pulmonary disease presents with signs of right-sided heart failure, namely jugular venous distension, hepatomegaly, and bilateral lower extremity edema. Therefore, his current condition is consistent with cor pulmonale. His arterial partial pressure of oxygen is low at 60. As we explained on one of the previous slides, hypoxemia causes hypoxic pulmonary vasoconstriction, increasing the right ventricular afterload. Increased right ventricular afterload causes concentric right ventricular hypertrophy, which then results in right-sided heart failure. This is the pathophysiology of cor pulmonale. Let's finish this lecture with pulmonary embolism. For pulmonary embolism, we'll discuss its definition, risk factors, clinical presentation, diagnosis, and management. A pulmonary embolism is a thrombus that embolizes from another part of the body to the pulmonary vessels. The most common source of pulmonary thromboembolism is the iliofemoral vein in the lower extremity. This is what we call a deep venous thrombosis. It's worth mentioning that a pulmonary thromboembolism can also arise from the upper extremity. Risk factors for a pulmonary embolism can be remembered by the Virchow triad. A mnemonic to help one remember the Virchow triad is SHE. S stands for stasis of blood. Stasis occurs in the setting of immobility, for example, during a long drive or flight, or postoperative immobilization, to name a few. H stands for hypercoagulability. There are many conditions that can make a patient hypercoagulable. Many malignancies, especially those producing mucin, are prothrombotic diseases. Pregnancy and oral contraceptive use can also predispose women to deep venous thrombosis and pulmonary embolism. This is because elevated estrogen levels stimulate hepatic synthesis of coagulation factors. Factor V Leiden is the most common inherited cause of hypercoagulability. It is caused by resistance of factor V to cleavage by activated protein C. Nephrotic syndrome is an acquired prothrombic state due to urinary stasis of antithrombin 3. Antithrombin 3 primarily inactivates factors 2A and 10A. Antithrombin 3 deficiency disinhibits factor 2A and 10A, predisposing the patient to venous thromboembolism. Protein C or protein S deficiency can also lead to pulmonary embolism because they normally inactivate factors 5A and 8A. Therefore, protein C or S deficiency will disinhibit these coagulated factors. Finally, E stands for endothelial damage. Endothelial damage can expose subendothelial collagen and initiate the coagulation cascade. Examples of endothelial damage include smoking and femoral vein catheter insertion. A catheter can accidentally damage the endothelium, promoting thrombus formation. Patients with pulmonary embolism commonly present with dyspnea, pleuritic chest pain, and cough that might be bloody. Blood in the cough can be explained by pulmonary infarction. The physical exam usually shows tachypnea, tachycardia, and an increased P2 component of S2 heart sound. There might also be signs and symptoms of deep venous thrombosis in the extremities, such as unilateral swelling, erythema, and pain in the leg. A 57-year-old woman comes to the emergency department due to tachypnea, tachycardia, and shortness of breath. She flew from Hong Kong back to New York yesterday after a business trip. Arterial blood gases reveal respiratory alkalosis, and the CT angiography reveals a filling defect in the left pulmonary artery. What predisposes this patient to her current condition? This patient presents with tachypnea, tachycardia, and shortness of breath. Her arterial blood gases reveal a respiratory alkalosis, and CT angiography reveals a filling defect in the left pulmonary artery. This is consistent with pulmonary embolism. Yesterday, she flew from Hong Kong to New York, which presumably was a long flight. Immobility and blood stasis during a long flight likely predispose this patient to the development of a deep venous thrombosis and pulmonary embolism. Let's move on to the diagnosis of pulmonary embolism. First, the patient is classified to have either high or low risk based on the modified Wells criteria for pulmonary embolism. Let's discuss these criteria. If the patient has signs and symptoms of deep venous thrombosis, he or she gets 3 points. 3 points are also assigned to the patient if the alternative diagnosis is less likely than pulmonary embolism. If the patient's heart rate is more than 100, then he or she gets 1.5 points. 1.5 points are also assigned in case of previous history of deep venous thrombosis or pulmonary embolism. Patients with recent surgery in the past 4 weeks or immobilization also get 1.5 points. Malignancy also earns the patient 1 point. Finally, hemoptysis also earns 1 point. If the total Wells score is less than or equal to 4, then pulmonary embolism is unlikely. In contrast, if the total Wells score is more than 4, then pulmonary embolism is likely. If the patient has low risk for pulmonary embolism, then we can perform D-dimer assay. D-dimer is a fibrin degradation product, and it can be increased in any prothrombic state. Therefore, D-dimer has high sensitivity and low specificity, and it is used to rule out pulmonary embolism. If D-dimer levels are less than 500, pulmonary embolism is excluded. If levels are more than 500, then we should perform a CT angiography. CT angiography is also performed as an initial test in high-risk patients. It has a high sensitivity and specificity for pulmonary embolism. However, CT angiography is avoided in pregnant women and patients with renal failure due to the IV contrast needed in this procedure. Ventilation perfusion scans, also known as VQ scan, are an alternative test to CT angiography. It is used in patients with contraindications to IV contrast. These patients include pregnant women and those with renal failure. Duplex venous ultrasound of the lower extremity looks for the deep venous thrombosis, but it does not directly visualize the pulmonary embolism. Here we see the ventilation perfusion of a healthy patient and the patient with a pulmonary embolism. The normal VQ scan shows the equal signals coming from both lungs. The areas of attenuated perfusion signal in the scan on the right suggest the pulmonary embolism. Arterial blood gases are commonly performed in a patient suspected of having pulmonary embolism. However, arterial blood gases are not diagnostic for pulmonary embolism. They show respiratory alkalosis due to a tachypnea and high AA gradient. The AA gradient is high because oxygenation is no longer occurring in the segment perfused by the obstructed pulmonary artery. Let's move on to chest x-ray. A chest x-ray is not specific or sensitive for pulmonary embolism. However, there are two x-ray signs associated with pulmonary embolism. A Hampton hump is a peripheral subpleural wedge-shaped opacity due to pulmonary infarction. Westermarck sign, on the other hand, is increased lung lucency due to oligemia or decreased blood flow to that particular lung segment. Here we have the chest x-ray image of a patient with pulmonary embolism. Please note this peripheral subpleural wedge-shaped opacity due to pulmonary infarction. This is what's known as Hampton hump. And here is another image of the patient with the pulmonary embolism. You can appreciate the enlarged right descending pulmonary artery and this area of increased lung lucency due to oligemia or decreased blood flow to that particular lung segment. This is what's called the Westermarck sign. Let's talk about management of a pulmonary embolism. Supplemental oxygen is given to correct hypoxemia. Unfractionated heparin or low molecular weight heparin such as enoxaparin or dalteparin are also administered for 5 to 10 days to prevent expansion of the current thrombus and prevent future thrombus formation. Unfractionated heparin is preferred in patients with renal failure because, unlike low molecular weight heparin, unfractionated heparin is not metabolized by kidneys. Contraindications for anticoagulation therapy include active bleeding, recent stroke, heparin-induced thrombocytopenia, and uncontrolled hypertension, to name a few. Heparin can be administered immediately without diagnostic tests in patients with high suspicion of pulmonary embolism. Oral anticoagulation therapy should also be initiated with either warfarin or novel oral anticoagulants, such as factor Xa inhibitors and direct thrombin inhibitors. Factor Xa inhibitors include apixaban, rivaroxaban, and edoxaban, while direct thrombin inhibitors include bivalirudin, argatroban, and dabigatran. We should continue oral anticoagulant therapy for 3 to 6 months, depending on the risk for recurrent pulmonary embolism. The goal of INR value for a patient on warfarin therapy with a previous pulmonary embolism is 2 to 3. Additionally, thrombolytic agents such as TPA can be administered acutely in cases of massive pulmonary embolism or right-sided heart failure associated with a PE. An inferior vena cava filter is used in patients with contraindications to anticoagulation. It is also used in patients with high risk of recurrent deep venous thrombosis. Finally, surgical thrombectomy is considered in hemodynamically unstable patients or in those not eligible for fibrinolytic therapy. Here we have an image of an inferior vena cava filter. As the name implies, it is placed in the inferior vena cava and prevents embolization of lower extremity thrombus to the lungs. Here we have an algorithm summarizing everything that we've discussed about pulmonary embolism. When a patient presents with a suspected pulmonary embolism, the first step in management is to determine if they are stable or unstable. Let's go through a scenario with a stable patient first. If they're stable and the clinical likelihood of a pulmonary embolism is high, then they should receive a CT angiography if it is not contraindicated for a reason like pregnancy or contrast reaction. If this reveals a pulmonary embolism, then treatment can be started. If the clinical likelihood is low, then a D-dimer test should be performed. If this is high, then a CT angiography should be performed as well, and if a PE is present, then treatment should be started. However, if the D-dimer is normal, then they should not receive any treatment for pulmonary embolism, and they should continue to be worked up for the underlying cause of their symptoms. Now let's move on to the other side of the algorithm, which involves patients with a suspected pulmonary embolism who are hemodynamically unstable. In this case, a bedside transthoracic echocardiography should be performed to evaluate for right ventricular dysfunction. If there is no dysfunction, then they should be evaluated for other causes of hemodynamic instability. However, if there is right ventricular dysfunction, they should be taken to immediate CT angiography if this is available. If CT angiography is unavailable, they should be treated as if they have a pulmonary embolism. If CT angiography is available and shows a pulmonary embolism, then they should also be treated. However, if it does not reveal a pulmonary embolism, they should be evaluated for other causes of right ventricular dysfunction that could lead to hemodynamic instability. The algorithm on the previous slide discussed the workup for a pulmonary embolism. Now let's take a look at the management. The first step in management of a suspected pulmonary embolism is to determine if the patient has an absolute contraindication to anticoagulation. If they do not, and their modified Wells criteria is less than or equal to 4, they should have a CT angiography or VQ scan performed before starting anticoagulation. If the angiography is positive, then they can be started on anticoagulation. If angiography is negative, then no further evaluation is required. In contrast, if a patient without contraindications to anticoagulation has a modified Wells criteria score greater than 4, then they should be started on anticoagulation even before there is confirmation of a pulmonary embolism. Now let's move on to the other side of the algorithm. If the patient has absolute contraindications to anticoagulation, then they need a CT angiography or VQ scan before deciding further steps in management. If either of these imaging modalities show a pulmonary embolism, then one should consider an IVC filter for this patient since they cannot receive anticoagulation. If there is no pulmonary embolism present, then no further evaluation is needed. Now let's take a look at a practice question to round out the lecture. An 81-year-old man is brought to the emergency department due to chest pain and bloody cough that started 2 hours ago. He underwent subtotal colectomy for an early stage colon cancer 1 week ago. He has past medical history of chronic kidney disease stage 4 treated with hemodialysis. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 90/60, a heart rate of 125, and a respiratory rate of 26. The physical exam reveals unilateral swelling, erythema, and pain of the right calf. Which of the following is the best next step in managing this patient? A. D-dimer assay. B. Unfractionated heparin. C. Enoxaparin. D. CT angiography. This patient presents with bloody cough and chest pain. Let's calculate his modified Wells score for pulmonary embolism. He has signs and symptoms of deep venous thrombosis, namely unilateral swelling, erythema, and pain of the right calf. These symptoms give him 3 points. He had recent surgery, worth of 1.5 points, and he has a colon cancer giving him 1 point. His heart rate is more than 100 beats per minute. That earns him an additional 1.5 points. He has hemoptysis, worth of 1 point. Finally, an alternative diagnosis is less likely than the pulmonary embolism, giving him 3 points. Therefore, Wells score for pulmonary embolism is 11, suggesting that his pretest probability for thromboembolism is very high. Additionally, he is hemodynamically unstable with hypotension and tachycardia, so we need to give him medications as soon as we can, even without performing the diagnostic test. The best next step out of these options is to administer unfractionated heparin to this patient. Therefore, the correct answer is option B. This is a slide reminding us of the management of the patient with pulmonary embolism. Let's explain why other options are incorrect. Option A, D-dimer assay, is incorrect because this patient is at very high risk of having a pulmonary embolism even if D-dimer comes back normal. It will not reliably rule out pulmonary embolism in his particular patient. Option C is incorrect because this patient has chronic kidney disease, and low molecular weight heparin, including enoxaparin, is avoided in patients with renal failure. Finally, option D is incorrect because although CT angiography is performed as the best initial test most of the time, this patient is hemodynamically unstable and we need to start treating him even before definitively diagnosing the pulmonary embolism. And that concludes our lecture on diseases of pulmonary vasculature.